I'm going to go over CPAP to start off with, and then we're going to go over some of the orogastric and tracheal tubes that we use just to clarify the difference. So let me start with CPAP. And before I give you the definition of CPAP, I want to let you know that CPAP is most often used in the NICU with preterm babies. We can consider using CPAP in the delivery room for a baby that has labored breathing, grunting, retracting, or persistent hypoxemia per oximetry, or it can also be manifested by persistent cyanosis. The baby must have spontaneous respirations. So this is not for your baby who's not breathing. This is not for your babies that are really going bad. This is an assistive process for a spontaneously breathing infant. We must use CPAP judiciously and consider it case by case. With term infants with normally expanded lungs, it could actually cause an air leak or a pneumothorax. So if we do use CPAP, which hopefully in our setting we won't, but I do need to review it. Hopefully by the time that CPAP is considered, there'll be an NI team here from Lafayette General. We really need to consider this as a last case scenario in our setting, since we do not have the proper setting to deal with a pneumothorax if we were to cause an air leak. So what is CPAP? CPAP is continuous positive airway pressure. It is a method of PPV that's used for the babies who are breathing spontaneously. It's done to keep the alveoli open at the end of the exhalation and thus increases the oxygenation and reduces the workload of breathing on the baby. Again, CPAP cannot be given with a self-inflating bag. We will need to use one of the flow inflating bags that we've already gone over. So let's go back to our algorithm. This is the right side of the algorithm. And the question is, what if the baby is breathing and the heart rate is greater than 100, but the baby remains cyanotic? Or what if the baby is breathing and the heart rate is greater than 100 beats per minute, but the baby is experiencing labored breathing or grunting or retractions of the chest or has persistent hypoxemia on the oximetry or has the persistent cyanosis? So acrocyanosis is normal. Acrocyanosis is limited to the hands and feet. Most babies, because of the in utero oxygen saturation level, take a little while for the hands and the feet to pink up. So acrocyanosis is different than persistent central cyanosis. Healthy babies may have central cyanosis for several minutes. However, if the central cyanosis persists, we need to apply a pulse oximetry and see if the reading is consistent with hypoxemia. We always place the oximetry on the right hand or the wrist. And remember that healthy newborns transition from 60%, which is the normal in uterine state, to 90% as a more gradual or eventual state. So we don't want to jump on top of CPAP too quickly. So if the baby is having some labored breathing, grunting, retracting, or particularly persistent hypoxemia or persistent central cyanosis, we can start off with, of course, positioning the airway and clearing the airway and making sure that we have an SpO2 monitor on and administering supplemental oxygen. Now, the supplemental oxygen, the percentage level, we want to start with 10 liters per minute at a blended percentage of 30%. We can increase this depending on the baby's response to the blow-by oxygen. So if we start at 30% and we see a rise in the O2 sat, but we are not meeting our goals, we can increase it to 40%, 50% just for blow-by purposes. If it is not increasing the oxygen saturation in the baby, then we need to consider CPAP. We want to never administer free flow oxygen via our self-inflating bags due to the lack of reliability of flow through the mask. So blow by, if the baby is not doing well, we might as well grab one of the free-flowing oxygen bags, the green surgical bags with the manometer on it. So when we're administering CPAP, we want to go ahead and make a tight seal between the baby's face and the mask. We need to test the CPAP amount before applying the mask to the baby. And there's a video after this that will show you exactly how to test the mask. We need to adjust the PEEP so the manometer reads 5 centimeters of water. And instead of pushing down on the baby's face, we want to go ahead and lift the baby's face into the mask instead of pushing against it. Once we've tested the pressure against our hands to ensure that the PEEP is at 5 centimeters of water, once we apply it to the baby's face, if the pressure is lower on the baby's face, then the chances are that we have a problem with the seal. We also never use more than 8 centimeters of water for PEEP. And if the baby is not breathing effectively, we need to consider positive pressure ventilation. So during this part of the algorithm, if at any point you feel like the baby is getting worse and is not breathing well, we need to go ahead and start positive pressure ventilation. And remember, during both CPAP and positive pressure ventilation, gas can enter the stomach. So we're going to need to use an orogastric tube to relieve this pressure. And I have a video at the end of this section that will show how to properly use that as well. So we need to adjust the PEEP so that the manometer reads 5 centimeters of water pressure, and I'm going to show you that in the video with the use of the free-flowing bag mask. We need to lift the baby's face into the mask instead of pushing against the baby's face. This can include the baby's airway because it can readjust the baby's position to a point where the baby's airway is not open adequately. We do not ever want to go over 8 centimeters of water pressure for PEEP. And if the baby is not breathing effectively, we need to always consider the use of PPV. And we will review the use of orogastric tube to relieve the pressure if gas enters the stomach. So let's look at a couple of videos. So when we're using CPAP, we're going to be using the flow inflating bags that we discussed in earlier lessons. And we're going to look at the manometer, okay? It's really important that we check the manometer to see what the PEEP is when the mask is occluded. So we occlude the mask, and if you look at the manometer, it's going all the way up to 25 centimeters of water pressure. But we want to start our PEEP at 5 because we're just wanting to slightly inflate the lungs between expiration for babies who are having trouble breathing on their own. So now what we're going to discuss is the use of CPAP. We're going to be talking about the right side of the algorithm. So if the baby is having labored respiration, or the O2 sat is not increasing, or the baby has persistent cyanosis after using supplemental oxygen, we may want to consider the use of CPAP. So for this lesson, what we're going to discuss is how to do the CPAP. But before that, I really want to go over what CPAP is and what the difference is between CPAP and positive pressure ventilation. CPAP is only used for a spontaneously breathing infant, whereas the positive pressure ventilation, you are rescue breathing for the baby. CPAP is a little bit different. What you need to know about CPAP is what PEEP is. PEEP is the amount of air that is maintained in the lungs between each expiration. So what CPAP does is it infuses oxygen during expirations to make sure alveoli in the lungs don't collapse. Oftentimes, premature babies do not have enough surfactant level, so their lungs will collapse between expirations, and term babies can experience this too. Let's review how we do CPAP. So administering CPAP, we want to maintain a firm seal on the baby's mouth. We're not going to be giving respirations. All we're going to be doing is giving the positive pressure in between ventilations to ensure that the alveoli do not collapse. So we want to make sure that we have a nice tight seal around the nose and the mouth of the baby. We're going to use the two-handed technique, and we're going to ensure on our manometer that we have a PEEP starting out at 5, as you can see on this manometer. The reason why I used a two-handed technique is because the two-handed technique, we can actually thrust the baby's jaw forward in order to open the airway to ensure that we're delivering the pee properly. Now, with CPAP, the highest level of PEEP we want to go up to is 8 centimeters of water pressure. We do not want to give any more than that, particularly in preterm infants, because it can cause a pneumothorax. So while administering either positive pressure ventilation or CPAP, air may get trapped in the baby's stomach. We need to get an 8 French or a gastric tube, a syringe, and I have some tape handy here. So what we're going to do is, while the positive pressure ventilation or CPAP is going on, you can actually measure it with the mask on. But I'm going to go ahead and show you what the measurement looks like. So we're going to start at the bridge of the nose. I'm going to go down to the earlobe. And then we're going to bring the orgastric tube to the middle of the abdomen, in between the xiphoid process and the umbilicus. And we're going to mark the distance. Okay? The distance here is 11 centimeters. So now what we can do is we can go ahead and insert the 8 French into the stomach. We go ahead and manually insert it until we get to our predetermined marker. So I've reached my 11 centimeter marker, and I'm going to go ahead and I'm going to gently tape it on the side of the baby's face. So what I can do now is I can go ahead and attach the syringe, and of course any positive pressure ventilations or CPAP can continue. But what you will be doing is pulling back on the orgastric tube to remove any gastric contents or air that is trapped in the stomach. Once you feel like you've removed everything that you can, go ahead and take the syringe off, and you can leave it open and out. That way, once you're continuing your CPAP or positive pressure ventilation, if any air does go down into the stomach, it will be released by your orogastric tube. The next thing we're going to review is the meconium aspirator. It's a little plastic device. We will use it with an ET tube of the corresponding size for the size of the baby or gestational age of the baby. So what we're going to do is we're going to go ahead and intubate the baby using our ET tube. So once we've inserted the endotracheal tube, we insert our suction directly to the meconium aspirator. We can go ahead and occlude meconium aspirator, pulling out over 3 to 5 seconds in order to get out all of secretions that are blocking the baby's airway. The next tube I'd like to discuss is the suction tube that we can actually use to suction the trachea directly into the ET tube. If we feel like we have some occlusions with thick secretions or meconium within the trachea, we can actually insert the corresponding suction tube into the ET tube until we meet mild resistance, and then occlude the suction tube for the 3 to 5 seconds while withdrawing to withdraw any fluids that have been lodged within the trachea. Another thing I'd like to review is thermoregulation for preterm babies. With preterm babies, we don't need to use a towel to dry the baby because they're at an increased risk of hypothermia and cold stress. So what we can do is we can go ahead, and this is a pretty big baby for the demonstration. Normally our pretermers are going to be considerably smaller, so a large gallon-sized Ziploc bag or some type of polyethylene plastic should be wrapped around the baby without drying the baby. What that will do is that will encapsulate any possibility for the baby to experience evaporative heat loss. So for our really preterm babies, 32 weeks or less, or babies that are especially small for gestational age, we want to go ahead and wrap them in polyethylene plastic. We're going to do all of the other stuff. The baby should have already had a cap on, is already placed under the radiant warmer. There's a thermal mattress under the baby. We're going to do all the other activities that we would except dry the baby. Instead, we're going to place them directly into a plastic bag.